And go ahead, Tim.
Well, good morning. I'm Tim Sheehy, president of the Metropolitan Milwaukee Association of Commerce, and welcome to the business of Metro Milwaukee. This monthly webinar spotlights the challenges and opportunities faced in sustaining and growing the region's prosperity. Insights to help you with your business so your business can help shape the region's future. But first, a word from our sponsor, United Healthcare. United Healthcare partnered with MMAC to offer businesses with 5 to 99 employees a health plan that works for both your employees and for your bottom line. It also gives your company an option to add other United Healthcare plans to your benefits package. So find out why over 300 companies with 11,000 covered lives have joined this United Healthcare plan. Contact an MMAC affiliated broker to receive discounted rates on United Healthcare's All Saver plans. Visit MMAC.org to learn more. Well, as much as we would like to be looking back on COVID-19 at this point in 2021, it looks like we're going to be working with it for some time to come. As the economy picks up, as events return to the schedule, schools begin to open, and employers work out what return to the office means, there's no better source to turn to than the Medical College of Wisconsin to help sort out where we are with COVID and how best to protect our gains going forward. Joining us today are Dr. John Raymond, President of the Medical College of Wisconsin, Dr. Ben Weston, Associate Professor and Director of Emergency Management, and Mara Lord, Senior Vice President of Engagement and Planning. Thank you all for sharing your time and your expertise. And if you're listening, again, if you have questions, please add them to the Q&A or chat box, and we'll answer as many as we can. So with that introduction, Dr. Raymond, I'll turn it over to you.
Thanks, Tim, and good morning, everyone. As Tim kind of set up, we are in a new surge of the pandemic, driven largely by the Delta variant, and largely for individuals who have not been fully vaccinated from COVID-19. So if we go to the next slide, I'll show you some data. We had over 1,000 cases per day, 3 times since the end of last week. And this would be our highs for the last 6 months. And we're still on the uptick. So things are trending unfavorably. The positivity rate in Wisconsin also is trending upward, which is unfavorable, at 7.4% for our 7-day average. And remember, we'd ideally like to see that declining and be significantly below 5%. And the reproductive number, which is a measure of contagiousness, which we would like to be significantly less than 1, was 1.2 yesterday, and actually is trending up at a rate that would be much higher than that. We had a few days when the R number was 1.9. So it is trending upward in an unfavorable direction. Just to put things in perspective about where we are right now in the pandemic, we had a 259% 14-day increase of new cases, and that would rank us as the 2nd worst state in the country behind New Hampshire, and 149% 14-day increase of hospitalizations, which would rank us as the 4th worst state in the country behind Vermont, South Carolina, and Mississippi. And again, these numbers are the highest that we've seen in 6 months. We've also fallen behind from our previously favored position in terms of completed vaccinations when we were in the top 5, then the top 10. Now we're 21st compared to our peer states in terms of vaccinations. Next slide, please. Thank you. The good news is so far we haven't seen a significant uptick in deaths, which is obviously one of the most important variables that we want to track with COVID-19. We do expect, if we track along the experience of other states and other countries, that the deaths will start to rise, but we won't see the significant numbers of deaths that we were experiencing last November. Hospitalizations, as I mentioned, are at a 6-month high with 481 hospitalized yesterday, and an ICU census of 160, which also is a 6-month high. And you can see similar numbers tracking along in Milwaukee. Next slide, please. This is a Milwaukee-centric slide, and I want to draw your attention going from the left to the right, which basically shows the weekly case burdens in each of our 72 counties. Red is the worst, dark blue is the second worst, medium blue is the third worst. And as you can see, we were in a very, very bad place last November, with most of the state having critically high burden of disease in the counties, with a few counties that didn't, were at very high levels. We showed significant improvement early in the year. And then in late June, we really reached a point where it looked like we might be turning the corner in the pandemic, with low and medium burdens in most of our counties. Unfortunately, that started to turn around in early July. And as you can see on the last picture of Wisconsin, every county in the state either has high or very high burden of COVID-19 cases over the previous 2 weeks. And I want to draw your attention to the circle on the lower right. That's us in Milwaukee. We're the only county that has a very high burden of disease. But what I would point out is, again, most of the counties not only have a high burden of disease, but the trajectory is going in an unfavorable direction for nearly every county in Wisconsin. So we can expect the case burdens to go up at least for the next couple of weeks. And next slide, please. Just want to point out to everybody, we've shown this slide before. This is the World Health Organization nomenclature for COVID-19 variants. And we know that COVID-19 continuously mutates. And when enough mutations occur so that the biology and epidemiology of the disease either theoretically could change or has been documented to change, then that variant would be classified either as a variant of interest that has theoretical changes in the biology or epidemiology, or a variant of concern, which has different characteristics, such as different transmissibility or contagiousness and different levels of severity. Right now, there are only 4 variants that are characterized as variants of concern by our CDC, and those are shown in purple at the top. We're also tracking a number of other variants that are variants of interest that may have different biology that may be unfavorable, but haven't necessarily gained a strong foothold in the US or in other countries. The one I want to focus on is Delta, which now constitutes about 95% of the new cases documented in the US, and which clearly has different biological characteristics than the previous versions that we were dealing with late last year and then early in 2021. Next slide, please. So the Delta, it is the most transmissible strain detected thus far. It's at least twice as infectious as Alpha or Beta, and it can be spread very easily by asymptomatic individuals, whether they're vaccinated or not. And that's something that we really have just learned over the last month, that clearly fully vaccinated individuals can get COVID-19. They generally don't have many symptoms or any symptoms, yet they have high viral burdens and can unwittingly pass that along to unvaccinated, vulnerable individuals around them. Now, the good news is that the transmission risk is reduced by anywhere from 50 to 80%, but there's still a significant remaining risk. And that's why the CDC recommends, and we recommend, that fully vaccinated people still wear masks around others to reduce that risk of unwittingly passing COVID-19 on to someone who's vulnerable. And as I mentioned, the viral burden in the nose, mouth, and throat is 100 to 1,000 times higher than the previously detected strains. And that's probably one of the many reasons why Delta is so contagious. The intrinsic R value of Delta also is much higher than other COVID strains, being estimated to be somewhere between 4 and 8. And that 8 number is significant because that's around where chickenpox is, just in terms of contagiousness. And we know that is an extremely highly contagious disease. Another thing that's different about Delta is that the primary symptoms aren't necessarily the ones we were looking for with previous variants of COVID. And they're headache, sneezing, runny nose, sore throat, different from and more subtle than the symptoms we saw with earlier variants. So many people could be infected and not really know it. They may think they may have a flare of allergies or a cold. So continuing vigilance is very important. We also know that for Delta, the likelihood of hospitalization is increased. And we're also seeing that younger people are getting sicker quicker. Hence the phrase younger, sicker, quicker, really to describe the impact of Delta compared to previous strains. We also know that Delta, like the Lambda strain that may be emerging, has partial escape from vaccine immunity. And I want to make sure everyone knows what this means. It doesn't mean that vaccination is futile. We still have a very strong immune response, but you must complete the full course of the mRNA vaccines to get about 90% protection. So we still strongly recommend that people be vaccinated and complete the series. And as I mentioned, Delta now constitutes over 90% of the cases in the US. Next slide, please. I hate to say this, but we now also know that Delta clearly can be transmitted outdoors. It's less likely to be transmitted than in indoor settings, but this also is causing all of us to rethink mitigation measures when we're outdoors. In particular, when we're in tightly packed crowds where they're shouting or singing, which would be expulsion of large viral burdens, prolonged exposure, and in settings where people may be unvaccinated or may not be wearing masks. And some recent examples of outdoor activities that have been associated clearly with COVID-19 transmission are shown there. The Lollapalooza, the famous Where's Waldo picture shown at the upper left, a couple of music festivals in Pendleton, Oregon, the Whiskey Music Fest, and a music festival from Brooklyn, Michigan called the Faster Horses Festival, all have been associated with clearly documented transmission of COVID-19 Delta variant. Next slide, please. And I don't want to take the shine off our pride in the Bucks winning the world championship. All of us had every reason to celebrate, but as we know, there are 500 plus individuals that are being tracked for probable spread that occurred during the celebrations for the Bucks victory. And as you can see here, again, outdoors, but tightly packed, people shouting, prolonged exposure, no masks, and lots of folks that probably are unvaccinated. Next slide, just another picture of the celebration. And so if I can go to the next slide, I do want to address a question that all of us are hearing about a lot, which is if vaccinated individuals still can get COVID-19 and they can spread it to other people, why bother getting the shot? Well, there are three reasons, and these are very straightforward and simple, and we hope that you will internalize these and share them with your friends who are also questioning why to get a vaccine. First of all, we know that COVID-19 vaccines reduce severe disease and hospitalizations by greater than 90%. So you get a very, very strong protective effect from severe disease. We also know that COVID-19 vaccines prevent COVID-19 related deaths by 99.99%. So this is really a remarkable degree of protection that you get from the things that matter the most. Disease severe enough to put you in the hospital and to cause you to die. And we also know that even though people who are fully vaccinated, who have COVID-19 can pass it on to other people, there is a reduction in the risk of transmission. Let's be conservative and say it's about 50%, which still means you need to wear a mask. So that gets to the next question. Why do vaccinated people need to wear masks and practice other mitigation measures? Let's make sure everyone understands, as amazing as these COVID-19 vaccines are, they were never intended to, and it was not a reasonable expectation to think that they would give us 100% protection all of the time. And they don't. There's never been a therapeutic or a vaccine that's been able to do that for us. So we know now with the emergence of Delta, and possibly in the future with the emergence of other highly contagious and possibly more severe versions of COVID-19, that we will wear masks to protect those around us. And remember, vaccinated individuals can have mild COVID-19 symptoms or even no symptoms and still be infected, have high viral loads, and be able then to pass that on to vulnerable individuals. That's why other mitigation measures are really important, not just at the individual level, but at the community, the society, the business, and the employer level. And with that, I'd like to turn it over. One more slide, please. Just want to talk about, we know that COVID-19 keeps changing, and we're all frustrated. We feel like people are moving the goalposts. Really, we're just trying to stay one step ahead of COVID-19, and it is changing. So I just want to lay some groundwork for thinking about things that could change the trajectory of COVID-19 in the future and might actually change our thinking about COVID-19. First of all, right now we're grappling with a lack of vaccine confidence that is really limiting our ability to squelch COVID-19. We also are tired of both personal and community mitigation measures like masking, distancing, lockdowns, avoiding crowds. And now we've learned that you can pass COVID-19 along outdoors. That's disheartening, and it may cause people to feel like they're helpless and that anything that they do isn't really going to contribute to getting COVID-19 under control. We've got to be vigilant about the continuing emergence of new COVID-19 variants. And I think all of us need to understand that we really can't go back to a new normal that looks like an old normal until the entire world has been vaccinated. And let me explain that. Even though we can get things under control in our country and we can relax mitigation measures, we still have to be mindful of what's happening elsewhere. Every infection that a person has is an opportunity for the virus to mutate and reinvent itself in a nastier way. And there are billions of people in the world who've not been vaccinated. Many of them do not have access to the high quality of healthcare we have here. And so they may get more severe disease that lasts longer. So you can have more and more replication events. So as we turn the corner here, and I'm sure we will in the US at some point, hopefully in the next few months or so, we still have to take responsibility for getting the rest of the world vaccinated, or COVID-19 could boomerang back to us. Now, I do want to talk about some promising developments. We do expect that the FDA will approve the mRNA vaccines within the next few weeks, probably Pfizer, maybe by the end of August or the first week in September, and Moderna by October. Our pharmaceutical companies are ready and able to manufacture significant quantities of booster shots or newly customized vaccines that could address emerging COVID-19 variants very quickly. That'll be easy for us to do, and we should be confident in the safety and the efficacy of those vaccines. And then something we haven't talked about before that is very promising news is on the therapeutic front. There are 3 pharmaceutical companies that are in phase 2 or 3 clinical trials trying protease inhibitors, which attack the virus in a different way, stop it from replicating. And these could be used for prophylaxis or for mild cases of COVID-19 and might actually be available by early 2022. And the reason I'm bullish on this strategy is that protease inhibitors were the singular type of compounds that we use to get HIV under control. And with that, I'll turn it over to Mara Lord. Next slide, please.
Thank you so much, Dr. Raymond. So we thought it would be helpful for you to hear not only from the scientific and medical perspective, but also just what are the hearts and minds of individuals at this point in time, specifically about vaccine, because as Dr. Raymond said, vaccine is the fastest way to us moving out of this pandemic. So the data that I'm sharing here, these are from the Kaiser Family Foundation dashboard, and I would encourage you to take a look at their vaccine monitor dashboard. It is really helpful and just gives you a good sense of hearts and minds across the nation. And what we found is that those data are quite reflective of how people in our own community are experiencing vaccine and are feeling about vaccine. So first of all, on the left-hand side, that pie chart, 1/4 of unvaccinated adults say that they will get vaccinated by the end of 2021. So that's not as many as we would like, saying that 26% are somewhat likely or very likely to get vaccine is helpful to see, but we obviously need to continue continue to move that forward. Take a look at the right-hand side. It says majority of unvaccinated adults actually believe that getting the vaccine, so I just want to make sure that you hear this, getting the vaccine is a higher risk than getting COVID-19. And so if you look at the wait and see column, 50% of those individuals who are unvaccinated and saying, I'm still going to wait and see, 50% they're really on the fence. They're saying, I'm not sure which is higher risk, but I'm not ready to take that vaccine. But look at the definitely not adults and that column. You see that 75% number. These are individuals who are saying, I think it's a higher risk to get the vaccine. What we found about those who have said definitely not to the vaccine is that there's been a really consistent stance by these individuals. They've really not changed their mind. They've said it since the very beginning, I'm not doing it. I'm not, and not really taking any consideration to get the vaccine. So, we're up against myths. We're up against a very deep belief system, and we're up against misinformation that has just proliferated across many different mediums. Next slide, please. So continuing in just vaccine attitudes and intent for adults. So among unvaccinated adults who acknowledge the spread of the variants in the United States. So these are individuals who are saying, yes, I know that COVID-19 is there. I know that there's a spread of variants. Really, more than about 35% are taking protective actions. So Dr. Raymond mentioned these, continuing with protective measures. And I wanted to just emphasize with that when you look at the columns that say unvaccinated and wait and see, in that unvaccinated column, about 37% of unvaccinated individuals are choosing to wear masks in public at this point in time. So they're making a new decision to wear masks in public. And about 40% of those unvaccinated individuals are avoiding large gatherings. And you can, of course, compare that with the vaccinated column as well. A little bit higher percentage in the wait and see group. So that, which is, I think, helpful to see and encouraging that more individuals are taking some of those protective actions. So wearing a mask and avoiding large gatherings. Next slide, please. So Dr. Raymond also mentioned just the up and coming promising development coming up and hopefully full approval from the FDA for vaccines. So what I was really interested to see is that 31%, and actually probably the middle column is more important, the 49% of those who have said they're going to wait and see to take the vaccine, 49% of those individuals are saying, I am more likely to get the vaccine once it receives full approval from the FDA. That is really encouraging to me and just speaks to the motivation and speaks to how all of us need to be talking about that FDA full approval once it comes our way, that is something we should really amplify. I wanted to also just emphasize some of these other items. So 31% of individuals who said they're going to wait and see said that if they were entered into a lottery with a chance to win $1 million, they would probably get the vaccine. But take a look at the difference between winning a $1 million lottery and the vaccines receiving full approval. That's a significant difference. And it looks like that full approval from the FDA is even more motivating than the chance of winning money. The other piece I wanted you to hear is that people are saying that employers, if they gave me time off to get vaccinated and recover from side effects, that, overall about 21% are saying that would be motivating to them. And then a mobile vaccination clinic coming to their community. I'll talk about that in a moment because we have a lot of those efforts going on in this area. And then, of course, incentive offerings continue to be an opportunity for motivation, but not a significant motivation. So the takeaway from me from this slide is to say that this sense of belief, what you believe about the vaccine, or people being concerned about what the vaccine means to them, is really important for us to keep our eyes on. And hopefully once the FDA moves towards full approval, we'll see some change. Next slide, please. So I wanted to emphasize for a moment here that parents, the attitudes and intent of parents. So at this point in time, and this is as of late July, less than 50% of parents already have vaccinated or will vaccinate their child or their children between the ages of 12 to 17. So it's just under 50%. You can see 18% are saying wait and see, 25% are saying definitely not. Again, once there is FDA authorization approval, I should say, we're hoping that some of that will change. And then just looking to the future for children under age 12, nearly 70% of parents are hesitant right now to vaccinate their child or children at this time. But again, we've seen some of those fluctuate over time. Next slide. And then focusing on employees for a moment here. So it's always interesting to see who the influencers are. And you can see that among employed individuals who were surveyed, employers really rank among the most trusted in providing reliable information about COVID-19 vaccines. You can see that for those who do have children under age 18, they're looking to their pediatrician. 83% are looking to their own doctor. And this has been a theme throughout the entire pandemic, that people's own physician encouraging them to get vaccine is truly one of the best ways to move people in that direction. And then health insurance companies are playing a role. But look at employers. 72% of individuals who are employed are saying that their employer is a trusted source. And so we really do encourage that employers take a role of sharing information, making sure that that information is valid and is validated and is factual, scientifically evidence-based, and bringing that to your employees for discussion. And then you can see CDC, FDA, and Public Health Department as trusted sources as well. And I think I have one final slide. So I just wanted to mention that in the Milwaukee area, we have many of us partnered, Dr. Weston, myself, many community organizations, Milwaukee Health Department, other vaccinators across the county. We found that at this time, one of the best ways to get vaccine to individuals is actually going door to door. And so what you see here is the effort that we've put together, pairing community mobilizers. These are individuals who are trained to have a conversation, knocking on a door, have a conversation about health matters, about vaccine, and then pairing them with a vaccinator who can literally come to someone's door, on their porch, in their living room if they choose, and provide a vaccine to them. So we've been able to cover 2,900 households so far, and this is continued. It's Tuesdays through Saturdays. We have mobilizers by census tract going into neighborhoods, and we've been able to vaccinate about 443 individuals as of Saturday in their homes. And so this has become a very effective way to reach people, and meeting people where they are, both in their hearts and minds, but also in their homes, has shown to be a very good way to reach. So I will conclude there, and Tim, hand it back to you.
Tim, you're muted.
Tim, you're on mute. You might want to just take yourself off.
Thank you very much, Mara. So I was going to say we're going to invite Dr. Weston and Dr. Raymond back, and whoever feels most apt to answer the question. I've got a lot of them, and I'll put them out here. So the first one really relates to folks that have had COVID and are carrying the antibodies. And the question is, do they still need to be vaccinated? And if so, why? Why is getting COVID and the protection from the antibodies not as strong, or is it not as strong as getting a vaccination?
So I'm happy to start here. So what we've learned and continue to learn about individuals who've had COVID in the past is that the immunity provided by that natural infection is inconsistent. Some people seem to have very good immunity. Some people seem to have shorter lasting immunity and not as robust immunity. And it's important to remember there's more than just antibodies to immunities. There's the B cells that's in our bone marrow. There's the long-term kind of memory immunity as well. And so what we found from multiple different studies is that people who've had natural infection from COVID have some degree of immunity. Again, it's inconsistent. If those people go on to then get the vaccine, they actually have quite robust immunity. In many cases, it seems better immunity than people who just had the vaccine. So if anything, I would say it's added incentive for somebody who has had the COVID infection to go and get the vaccine and get as robust immunity as possible.
Great. Thank you. I appreciate that. Other question here, a number of them. Can you discuss the level of COVID testing? Is it adequate? Are businesses doing it along with healthcare facilities, public health, and pharmacies?
So I'll jump on that one. Testing is still robust in our community, and there's still lots of options and places to get tested. When we look at Milwaukee County in particular, and Wisconsin as well, we've seen an uptick in testing, which makes sense. It goes along with this increase in symptomology that we've been seeing. What we're not seeing is the same levels of testing for our disease burden that we saw back when our disease burden was equally high in the winter. And so it does suggest some level of under testing. I think that's in part because people frankly have COVID fatigue and don't want to go out and get tested. And it also may be that there's less messaging about testing as well. So I think the take home point is that it's just as important as ever to get tested. And there's lots of opportunities out there to get tested, whether you're symptomatic or you've had a close exposure.
Question for those coming back to the office or in a work setting, how effective are masks against the Delta variant? And are we talking, I'm assuming also we're talking about different levels of masks, that an N95 is going to be better. So I come back to work, people are wearing masks. How protected am I from the Delta variant?
Maybe I'll start here. And I can tell from some of the questions that have been submitted, there's still some mask skepticism. Masks are one of many strategies that we use, layered strategies, to reduce the risk of transmission of COVID-19. And what we know from earlier in the pandemic, from many different types of studies, laboratory studies, epidemiology studies, clinical studies, surgical masks and N95 masks give outstanding protection. And at least for the strains before Delta, cloth face coverings with multiple layers also gave you a good degree of protection. I think it's an open question now about how much protection you get from the different types of masks with Delta. And Dr. Scott Gottlieb, former FDA commissioner, has been pretty strong about advocating for N95 masks or surgical masks for people that are going back into the workplace if there are questions about the HVAC that you have, questions about the density and the length of interactions that you have with other people. In other words, if you're indoors without good circulation, you're in close proximity with other people for long periods of time, that you may want to consider upgrading your mask either to a surgical or an N95 mask. And that's an evolving area just in terms of Delta. But we still are strongly recommending multiple different types of mitigation measures in the return to work setting and when people are out shopping and doing daily activities. And Ben, I know you've been deeply immersed in some of the conversations at the county level. Anything that you want to add?
I think it's a great summary. Different masks provide different levels of protection, but as Dr. Raymond said, I think the best way to think about it is that layered approach. So think of it as when you drive your car, you don't just wear your seatbelt and consider yourself safe. You have seatbelts, you have airbags, you have anti-lock brakes, you have sensors, you have all these different things that work together to keep you safe. And I think masks are one of those layers. Distancing is one, open air and ventilation is another. Vaccine is one of the most important. So we have to use them in a layered approach.
Yeah, Dr. Westman, Dr. Raymond, I want to come back to this question again because it keeps coming up and you answered it, I think, well the first time, but can you speak a little bit to the science around natural immunity? How much does a vaccination help folks that have previously had COVID? And are there any studies that show there are side effects that are greater if you've had COVID and then get vaccinated?
I'll start. That people are concerned that if they had COVID, when they get vaccinated, they may have a more vigorous immune response and fever, aching, nausea. And we have seen that with people with previous COVID infections have a pretty strong reaction to the vaccine. In terms of any evidence that there are long-lasting negative side effects for people that have had COVID-19 and get vaccinated, I'm not aware of any. And you are going to get much stronger immunity. I want to amplify some of the things that Ben said. We know that there have been severe breakthrough infections in previously infected patients with COVID-19 in multiple settings. So for example, in South America, when the Gamma variant, which was the old P1 variant, was circulating, people were getting reinfected and dying from COVID-19. We are not seeing a lot of people getting seriously ill if they've been vaccinated and then get infected with COVID-19. In general, we also know that vaccines give a stronger immunity than quote unquote natural immunity. And this is a persistent concern, rumor, myth that we have tried to address since the beginning of the pandemic that just won't go away. Natural sounds great, but it isn't necessarily better than vaccine-induced immunity. And particular for COVID-19, we know, and Dr. Weston mentioned some of these things, antibody responses are much more vigorous and durable with vaccines than with a previous infection. T-cell immunity, which is that long-term memory immunity, is much more robust and much more significantly activated by vaccines than by a previous COVID infection. And then B cells, the bone marrow cells that are activated, that are the factories that produce antibodies, also are much more vigorously stimulated by a vaccine than they are by a previous infection.
Okay. The mRNA vaccine is mentioned. Do you have any updates on the J&J vaccine and if it'll hold up against the Delta strain?
Yeah, so far it's holding up against the Delta strain. Like the mRNA vaccines, it has reduced efficacy. And there are some countries that are cross-vaccinating with a second dose of mRNA vaccine for people that have either gotten the Johnson & Johnson or haven't completed their course, but there's still pretty good immunity.
Have there been any changes in the makeup of the vaccinations from kind of their first introduction?
You mean the formula?
Yes.
No.
Okay. Another question that comes up here is, as you look out ahead, which I know is difficult to do with this, it's going to continue to mutate just like the flu. It doesn't look like it's really going to completely go away. So what's the projection? Do we go out, as we go out forward, are we going to get boosters? And of course, that raises another question we've talked about, Dr. Raymond, is for those who've got vaccinated early on, how long does that initial vaccination last? And when will people be thinking about a third shot?
Ben, do you want to start?
Sure, I can start on that. So, one thing we know with vaccines is much like every vaccine, nothing lasts forever. And so at some point, that immunity will start to wane and we'll start to look to booster shots. I think it's a little early to know when that's going to be. But when we look at the people who were involved in the initial studies for Pfizer, for Moderna, the data is still strong that close to a year out at this point, vaccination is still strong. So it'll be data that we'll continue to watch, we'll continue to follow the evidence. But I think the answer is yes, at some point, we'll need a booster shot. And that booster shot may very well also contain some modifications to help with other strains that may be more vaccine resistant. So I don't think for those who are vaccinated, I hope everybody on this call, I don't think for those who are vaccinated that your vaccine is going to last forever. I think there will be boosters, there will be modifications to it to keep you protected in the future.
Yeah, and one of the questions here, again, I know it's a difficult one for you all because this is about risk mitigation, but a lot of questions about returning to office. How do I know, what indicators do I have that it's a low risk? We've got Summerfest coming up now. They just announced today that they're going to require proof of vaccination or a COVID test. So what are things that people should look at going back to the office or going to an event? Quite frankly, going out to dinner, going to a movie. How do people kind of measure the risk mitigation and what should they be looking for?
Well, maybe I'll start. First of all, I would start with some things in your community that modify the risk. So that the number of cases that you have in your county or wherever you're going in the previous 2 weeks and whether the trajectory is unfavorable or favorable. So that community burden of disease is variable that people don't talk about enough. I would say the percent of vaccination in your community also is a factor that you should consider. The higher the percentage of people that are vaccinated, the lower the risk. That doesn't mean it's zero. And then the setting that you're going to be in, what type of mitigation measures are people following and which ones are reasonable? Obviously in a restaurant, people aren't going to be wearing masks all the time. And so you would probably want to focus on distancing and how good the air circulation may be in that setting.
Mhm. A question here. Few people are dying from COVID. So why the persistent, in this questioner's words, hysteria? This is not going to go away. It's going to continue to mutate like the flu, and we need to begin to allow people to return to normal.
Well, first of all, I don't think anybody on this webinar is suffering from hysteria.
No.
We're trying to be responsible. And none of us are nihilists, so we're not just going to say we can't do anything about it, so we'll just let whatever happens, happens. Every individual has to make a choice about what they're willing to do to try to reduce their individual and our collective risk, and whether that fits with their lifestyle and their expectations. You know, our job is, as much as possible, without inducing hysteria, to make sure people understand this is a highly contagious disease that can kill people. And a mortality rate of 2% is not trivial by any stretch of the imagination. And we're also learning that anywhere from 10 to 30% of people that have had COVID have long-term, in some cases, debilitating symptoms. And unfortunately, that also seems to apply to kids and even to people who've been previously vaccinated. So again, I think if most people, if they would weigh all the risks and benefits, would say some mitigation measures make sense.
So here's another masking question. If only one person wears a mask, what offers the most protection? You wearing a mask and you are vaccinated, or the person you are interacting with wears a mask and they are not vaccinated?
Well, there's actually a really simple answer to this question. The person who is infected, if they wear a mask, you get the best protection. That's called source control. And that's been established for multiple different respiratory diseases.
And then maybe if we get a chance later on, we can put up another questioner asking about mask data that shows the effectiveness against transmission. And there are some, I'm assuming, lots of studies on this.
Well, at the risk of being a self-promoter, I did review the literature, and now it's a little bit old because it was published in November of last year, looking at the studies that suggested there was a positive benefit and others that said there wasn't for wearing masks. And these are from epidemiology, laboratory, clinical studies, observational studies, and that's published in the November issue of the Wisconsin Medical Journal.
Okay. And again, lots of other questions about if this is going to be around. Is the recommendation that we're going to be wearing masks indefinitely?
In some settings, probably. Yeah, go ahead, Ben.
Oh, no, please. I was going to say the same thing. I think in certain settings, probably. When I go and work in the emergency department, I think for the foreseeable future, for a variety of reasons, I'll be wearing a mask. So I think medical settings are one thing. We did see a change. So when you look 2 months ago, we saw that in a lot of settings, vaccinated people with the virus that was circulating at that time were able to start taking off masks. Now, the situation has obviously changed. The Delta variant is quite different than what we were seeing a couple of months ago. But in time, the Delta variant will pass, much as it has in other countries, and we'll reassess our situation then, reassess what the evidence is, what the vaccine protection is, and go from there. So I think it is a dynamic situation. I don't think anybody can predict what the future will look like, but I don't think that what we're seeing right now is by any means our forever state.
I know we're supposed to wrap up at 11:45. I've got a load of questions. We still have a lot of people online. Are you all okay sticking around for a couple extra minutes?
Sure.
Great. So a lot of questions here on when the vaccine is going to get approved, what research shows on its impact for potential pregnancy implications or in young adults.
The Pfizer vaccine is very likely to be approved by the first week of September, and I expect Moderna maybe by October. And it shouldn't be a surprise. Almost 200 million people have received a jab with one of those vaccines, which is orders of magnitude more people than we normally follow to get full approval. Normally, what you want is a couple thousand to 50,000 people followed for 12 to 24 months, and we're we're vastly beyond that. So it should happen very soon. In terms of pregnancy, look, this is a very emotional issue, and I'm going to try to stick to as many facts as I can. There is strong evidence that the vaccines have a favorable safety profile in pregnant women. In other words, no different than other populations. So the risks aren't higher, just in terms of statistics, and the benefits are at least as good. We also know that pregnant women are amongst the most vulnerable individuals to have severe COVID-19. They are a high-risk group. We also know that the American College of Obstetricians and Gynecologists, the largest and most distinguished professional society who care for women, have recommended vaccinations for pregnant women, but they've also given the latitude for people to speak with their OBGYN or their family medicine doctor. And then healthcare systems are considering physician statements if a woman wants to be exempt because she's pregnant or trying to get pregnant, or they, in some cases, will allow for a pregnancy exemption without a physician excuse or whatever. So it is very emotional. It's very personal, and we have to respect that. But we're also trying to share some of the data.
Another question on extremely young children and how we can know about the impact on their still developing body systems. And Dr. Raymond, we talked about this earlier about how many vaccinations young children get that are currently in place.
Yeah, kids literally have to take dozens of vaccines when they're very young. And there's no, and again, I know that this may be controversial and emotional, but there's really no strong evidence that there are long-term risks from these vaccines that are significant, and certainly they wouldn't be anywhere near the benefit that people get. We're still learning about COVID-19 in kids, and I think the common wisdom 6 or 8 months ago was that kids probably don't get very sick from COVID-19, and the ones that do don't have long-term problems. We now know that actually isn't exactly true. Kids are getting very sick, and kids are getting long haul syndrome. And so, I would say that the risk of vaccination is far less than the risk of COVID-19 infection and long-term effects for kids. And that is becoming clearer and clearer as we go through the Delta surge.
A couple of questions on your opinions about employers requiring masks for everyone at work. And at this point, should employers reconsider requiring employees to return to the workplace?
Go ahead, Ben.
Sure, I can start on that. So when thinking about masks, I think the answer is absolutely, especially if it's an indoor setting with multiple people present. We see that Milwaukee County in particular, but much of Wisconsin, is in that substantial or high transmission category from the CDC. Right now, Milwaukee County recently transitioned from substantial to high, unfortunately. And those are the categories where the CDC recommends universal indoor masking. And so I think absolutely to the masking question, if you're indoors and around others. Now, if you have your own office and you can close the door, that's a different sort of situation, whether you can take your mask off in that setting. As far as return to work, I think it's depends on the individual business and depends on the type of interaction that business is going to have. But I think when appropriate, teleconferencing and doing meetings and larger scale interactions in that way right now with what we're seeing with the Delta variant is going to be an appropriate option.
Thanks, Ben. And maybe I can just add at MCW, we pushed back our phased return to work plan, return to on-site work plan for our non-clinical employees from September 7th to November 1, just so that we have some time to understand Delta a little bit better and so that we can ensure the safest working environment for our folks.
And then just to wrap it up here, a couple of questions. Do we expect or assume that Delta will go through the US quickly like it did in the UK and other countries?
Maybe. There's always a danger of looking somewhere else and saying it's going to behave exactly the same way here, because there are different mitigation measures, different cultural issues, different levels of vaccination. But, I would just wonder what quickly means. The downside or the decline of Delta in India took 3 months. And UK, it looks like it's going to be 3 to 4 months. And again, we're extrapolating a little bit. 3 to 4 months means it's going to take us to the holiday season here. And we're still on the upside of the surge. So I would just be careful about assuming that when things happen somewhere else, they're going to happen exactly the same way here. We just don't know.
And just a clarifying point, Dr. Raymond, you talked about what you've seen so far in terms of long-term effects on developing children, but we've only had this for a little while. So that still seems to be a hot point here.
It is, and I certainly understand the conundrum it poses to parents.
Yeah.
And just to expand on that briefly, it is, there's ongoing research on it, and the science varies, but it varies from long-term symptoms in children from 4% up to about 24%. And so even if you go on the low end, 4%, if there's an outbreak in a classroom, that's one of those kids that may be dealing with long-term symptoms of COVID, which typically include shortness of breath or concentration issues, things like that.
Yeah. Mara and Dr. Raymond and Dr. Weston, I want to thank you so much for your time. In the midst of all the questions, there's a lot of really good points in here about just the value of having direct access to folks like you to provide the best information that you have available. I know we have some requests here to start doing this weekly again. Hopefully we don't get in such a dire situation we need to do that. But again, I just grateful to have your expertise, the information. Mara, thank you so much for getting a lot of the answers online. And again, we'll try to give folks access to the best data that we have. For those that really want to dig into the studies themselves, we'll try and do that. I know how frustrating this is, but the only way we're going to move forward is with a dialogue like this that is not hysterical, that's directed at the facts as best we have them. And we want to continue to do that, to share that with our audience. And again, grateful for the three of you to join us today. And we'll look at getting back as soon as we can with information that helps you make better decisions for your business and better decisions for yourself. So please have a good rest of your day. And again, thank you all for joining us.
Thanks, Tim.
Thank you.
Thanks.